It's kind of unnerving when you stop to think about it, but air, something we rely on every second, can actually sneak its way into our bodies in some truly unexpected ways.
Hmm.
And if it happens to find its way into the brain's delicate blood vessels, well, that's where things can get really serious.
Yeah,
We're diving into cerebral air embolism today, basically, a condition where air bubbles block the crucial flow of blood in the brain's tiniest arteries.
absolutely. It's not something you hear about every day, but when it occurs, it really demands immediate medical attention.
Right.
We've got a really comprehensive chapter as our source material for this deep dive, and it lays out all the vital details pretty clearly.
Okay, so our mission today is to really get our heads around this whole thing. We want to understand the different ways these troublesome air bubbles can form and get in there, how they
Right.
cause such havoc in the brain, how doctors manage to figure out what's happening, and maybe most importantly, what can be done to treat it effectively.
Exactly, the whole picture.
We're aiming for those moments where it all clicks, the surprising facts that make you think, and the core information that really sticks with you. Okay, so let's start at the beginning. Where does this unwelcome air typically come from?
Well, the most frequent causes actually fall under the category of iatrogenic.
Iatrogenic,
Hmm.
meaning related to medical procedures.
Precisely. It essentially means they're related to medical procedures or surgery.
Mm.
Think about it. Anytime there's an incision made or a medical intervention takes place, there's a potential pathway,
A potential opening.
for air to inadvertently enter the vascular system.
Right, like during cardiopulmonary bypass. The source material mentions an incidence of around, 0.1%?
Something like that, yeah. But it also hints that it might be higher because it's not always immediately obvious or maybe gets missed.
That's a life-saving procedure for many, obviously, but it's startling to realize that air embolism is a potential complication.
It is.
What are some other examples of medical procedures that could lead to this? And maybe stepping back a bit, given how many procedures carry this risk, what are the key systemic factors? Like, is it mainly about pressure gradients or the nature of the interventions themselves?
That's a really good question. It's often a combination of factors. Uh, Neurosurgical operations, particularly those performed with the patient in a sitting position.
Oh, right, gravity.
Exactly.
Yeah.
Gravity creates negative pressure in the veins above the heart, which can essentially suck air in.
Wow.
In fact, air can enter the venous system in like 30 to 40% of those specific cases.
That high.
Yeah. There was even a reported instance during a lumbar discectomy, a back surgery, where hydrogen peroxide used for irrigation unexpectedly led to a massive cerebral gas embolism.
Hydrogen peroxide. How?
Well, it decomposes into oxygen gas, and apparently enough got into the system to cause a major problem.
Sure.
And while less frequent, neuroangiographic procedures, like when they use coils to treat aneurysms, can also inadvertently introduce small amounts of air, maybe around 0.08% incidence there.
Still a risk, though.
Definitely. It's estimated that there are around 20,000 cases of air embolism in the U.S. each year, all causes combined. Although, pinpointing the exact cause in every case can be challenging.
Why is that?
Well, partly due to underreporting, maybe, and also the fact that some smaller emboli might resolve on their own without ever being detected or causing major symptoms.
I see. So, medical interventions are a major piece of this puzzle. But what about other ways air can get into the bloodstream? I know diving is sometimes mentioned.
Absolutely. Diving-related air embolism is another important category. It can occur due to rapid decompression.
The bends.
Sort of related, but specifically air embolism here. When a diver ascends too quickly, nitrogen bubbles that have dissolved in their tissues under pressure can come out of solution and enter the bloodstream. Also, breath-holding ascents can lead to something called pulmonary overpressurization, sometimes referred to as burst lung or pulmonary barotrauma.
Burst lung that paints a vivid and slightly terrifying picture.
It does. Think of it like overinflating a balloon. If the pressure inside the lungs gets too high compared to the outside pressure during ascent, the delicate lung tissue can rupture, forcing air into the pulmonary circulation.
Gotcha. What other scenarios could potentially lead to an air embolism?
Trauma is another important category, cardiopulmonary resuscitation or CPR.
CPR.
Well, if performed on someone with an undetected lung injury, the chest compressions could potentially introduce air into the circulation through that injury.
Oh, okay.
Head and neck injuries can also create pathways for air to enter the vascular system.
Huh?
Even high-altitude accidents have been linked to air embolism in some rare cases.
Hmm.
And then there's some more unusual and thankfully much rarer causes.
Like
These include complications from unsafe abortions, Inhaling helium directly from pressurized tanks, which can force gas into the bloodstream under pressure.
Seriously, helium?
From a pressurized tank, yeah. Also, ingesting hydrogen peroxide, which we just touched on, it decomposes into water and oxygen gas in the body. We'll come back to that one. It's quite surprising.
Okay.
And even, believe it or not, orogenital sex during pregnancy.
Wait. Orogenital sex during pregnancy? That's unexpected. How does that even happen?
It's thought that forcefully blowing air into the vagina during pregnancy could potentially allow air to enter the maternal circulation through dilated veins in the uterus, or if there are small cervical tears. It's very rare, but documented.
Wow. Okay, definitely not something you hear every day. So we've got a better handle now on how this unwanted air can get into the body. What happens once it's inside? What are the mechanisms that lead to such serious consequences in the brain?
Well, in those iatrogenic cases we discussed, the
Yeah.
medical procedure ones, it's generally either drawn into veins due to negative pressure, that suction effect we talked about in the sitting position neurosurgery,
Right.
or it's introduced under pressure during a procedure, maybe from an infusion line or something.
Okay.
Interestingly, small amounts of air entering the veins can often be tolerated
Oh, why is that?
because the lungs act as a pretty effective filter. They're particularly good at trapping bubbles, larger than about 22 micrometers or so, especially if the air enters the system slowly.
So the lungs are like the body's first line of defense against these rogue air bubbles.
Precisely, a kind of safety net. However, if there's a rapid introduction of a large volume of air, what we call a bolus.
A bolus. Okay.
Yeah, typically more than maybe 1.5 to 3 milliliters per kilogram of body weight that can overwhelm the lung's filtering capacity.
Too much? Too fast?
Exactly.
Huh.
This allows the air to pass through the right side of the heart, through the pulmonary circulation, then into the left side of the heart and out into the arterial circulation.
And from there to the brain.
Potentially, yes. You can travel up the carotid arteries to the brain and block those tiny arterioles, which are around 30 to 60 micrometers in diameter.
Tiny vessels.
Very tiny. And because of air's surface tension, these bubbles are quite rigid. They can't easily deform to squeeze through the even smaller capillaries downstream.
Ah, so it's like trying to force a rigid marble through a very narrow, flexible tube. It just gets stuck.
That's a good analogy. It creates a blockage.
That makes a lot of sense. What about that patent-Foreman oval, or PFO? You mentioned that briefly. Sounds like it could play a significant role here.
It absolutely can.
Okay.
A patent-Foreman oval is a small opening between the heart's upper chambers, the right and left atria. Normally it closes after birth, but in some people it doesn't fully seal.
How common is that?
Surprisingly common. It's present in about 20 to 35% of adults.
Wow.
For these individuals, if air enters the venous system, this PFO provides a direct route, a shortcut, essentially for the air to bypass the lungs altogether.
Straight from the right side to the left side of the heart.
Exactly. And then out into the arterial circulation. This significantly increases the risk of a cerebral air embolism because the lungs, the usual filter, are completely bypassed.
That explanation makes the risk so much clearer. If you don't have a PFO, the venous air has to go through the lungs first.
Correct. It has to pass through the entire pulmonary vasculature first,
Okay.
where it would hopefully be filtered out if the volume isn't too large or too rapid.
Okay. And in diving-related cases, you mentioned pulmonary barotrauma, the burst lung. How does the air get from the lungs to the brain then?
So during a rapid ascent, the air trapped in a diver's lungs expands significantly because the external pressure is decreasing, right? Boyle's law again.
Right.
If the pressure inside the alveoli, the little air sacs, exceeds the surrounding tissue pressure by too much, say, 80 to 100 millimeters of mercury, it can actually force air across the alveolar capillary membrane into the pulmonary capillaries and veins.
Here's the lung tissue.
Microscopic tears, or sometimes larger ones. If alveoli rupture significantly, it can also lead to a pneumothorax air leaking into the chest cavity.
Okay.
But crucially, for cerebral air embolism, these air bubbles that enter the pulmonary circulation travel back to the left side of the heart.
And then
And then they get pumped out into the systemic arterial circulation and can head straight up the carotid arteries to the brain. Especially since divers are often in an upright position during their ascent, gravity helps send those bubbles upwards.
Okay, so the air bubbles, one way or another, are now lodged in the brain's blood vessels. What happens next? What's the actual damage these bubbles cause to the brain tissue?
Well, the immediate effect is that the air emboli lodge in the smaller arteries and arterioles, physically obstructing the flow of oxygenated blood.
Blocking the supply line.
Right. This leads to ischemia, a lack of blood supply, and hypoxia, a lack of oxygen reaching the brain tissue. This, in turn, can cause cerebral edema, which is swelling in the brain.
Swelling, dangerous in the skull.
Very dangerous. And interestingly, even after the air bubble itself dissolves or maybe moves on, a phenomenon called no reflow can sometimes occur.
No reflow. That sounds ominous. What is that?
It means that even though the initial blockage is gone, blood flow doesn't spontaneously return to the tiny blood vessels, the microvasculature, in that area.
Why not?
It's complex, likely involving damage to the vessel lining, swelling of the endothelial cells, maybe sludging of blood cells, but the result is persistent lack of blood flow even after the bubble is gone.
Wow. Okay, so no reflow. That certainly doesn't sound good.
It's a serious complication.
Ugh.
And it's not just the physical blockage we need to think about.
Oh, what else?
The presence of an air bubble acts as a foreign body within the bloodstream.
Like a splinter in the vessel.
Exactly. And that triggers a cascade of biochemical reactions. Blood platelets become activated near the bubble surface.
Like clotting cells.
Yeah, and they release various vasoactive substances, things like prostaglandins, which can affect blood vessel tone. The bubble can also directly damage the endothelial cells, the delicate lining of the blood vessels.
Okay.
This initial damage is often followed by the margination, kind of sticking to the vessel walls, and activation of leukocytes, types of white blood cells.
The immune cells get involved.
Right, and these activated leukocytes can actually contribute to secondary ischemia and inflammation in the affected area, making things worse.
So it's a snowball effect?
In a way, yes. And if an air bubble persists in a small vessel, platelets and fibrin, that clotting protein can deposit around it, kind of coating it.
Making it harder to dislodge.
Exactly, potentially preventing it from dislodging and causing a more persistent blockage. So it's not just a simple mechanical obstruction, it's this whole complex inflammatory response kicking in.
Right, the body trying to react but causing more issues. What about those tiny air bubbles sometimes seen during cardiac surgery? You mentioned there's some debate about their significance.
Yeah, that's an interesting area. While large air bubbles are clearly dangerous, causing immediate problems,
Definitely.
the clinical significance of the very small bubbles, often called microemboli, that are commonly detected during cardiac surgery is still debated.
Why the debate?
Well, we do know that post-surgical neuropsychological deficits, things like subtle problems with memory or concentration,
Brain fog kind of stuff.
sort of, yeah. Those deficits seem to correlate with the total number of embolic events a patient experiences during the procedure, picked up by monitoring like transcranial Doppler.
Okay.
However, our current monitoring technology often struggles to definitively distinguish between these gaseous microemboli, the tiny air bubbles, and particulate emboli, which could be tiny fragments of tissue, fat, or debris dislodged during surgery.
Ah, so you see an event but don't know for sure if it was air or something else.
Exactly. We also have difficulty accurately measuring their size in real time and precisely linking these small potential air bubbles to specific long-term neurological outcomes. It's hard to isolate their effects from everything else going on during major surgery.
That makes sense. It's hard to pinpoint the exact culprit. You also mentioned the blood-brain barrier earlier. How does an air embolism affect that crucial protective barrier around the brain?
That's another key aspect. Animal studies have shown that directly injecting air into the cerebral circulation can actually cause a temporary opening or increased permeability of the blood-brain barrier.
It breaks down the barrier.
Temporarily, yes. The good news is that this barrier, which normally tightly controls what gets into the brain tissue, typically seems to repair itself within a few hours after the event.
Okay, so it's not usually permanent damage to the barrier itself.
Usually not. And the level of ischemic hypoxia caused by a typical air embolism is often not severe or prolonged enough to cause large-scale brain infarction, a big area of dead tissue, like a major stroke.
But some damage can occur.
Yes, it can lead to localized necrosis or cell death, often in the deeper layers of the cerebral cortex, particularly at the vulnerable junction between the gray matter and the white matter.
So localized damage, but with the potential for recovery in some instances.
Precisely. There can also be other vascular effects. Following an air embolism, you might see a temporary segmental vasospasm.
A tightening of the vessel.
Yeah, a narrowing of a segment of the blood vessel, which might then be followed by a period of dilation or widening. It's even possible, theoretically, for some of the air to escape from the arterial side into the venous side through the capillaries, though the blockage is the main issue.
Okay.
But the key point is that the regional cerebral blood flow, the blood supply in the affected area, decreases significantly. And the EEG activity The brain's electrical activity measured on the scalp in that specific region might even stop temporarily.
Wow.
And one interesting difference from other types of strokes or blockages is that the permeability of the blood-brain barrier seems to increase almost immediately after an air embolism occurs.
Faster than with, say, a blood clot.
It seems so, based on studies. Short periods of this focal ischemia caused by the blockage are potentially reversible, as is the cerebral edema, the swelling, that can develop especially with prompt treatment.
That's hopeful.
It is. And it's important to remember, while we often focus on the brain,
Yeah.
the coronary arteries, supplying
Yeah.
blood to the heart muscle, can also be affected by air embolism.
Oh, right. Leading to heart problems.
Potentially, yes. Especially if the patient is in a reclining position when the air enters the system, as the bubbles might be more likely to travel to the heart's arteries.
And these animal studies you mentioned, they're useful but don't always perfectly translate to humans.
That's absolutely correct. Animal models provide invaluable insights into the basic mechanisms, the pathophysiology.
How it works.
Yeah. But the way it manifests clinically and how it responds to treatments can differ in humans due to our more complex physiology, maybe different blood properties, brain size, circulation patterns, things like that.
Okay.
For example, the observation in some animal studies that secondary CNS deterioration might be related more to endothelial damage or blood changes rather than just the mechanical bubble action.
The lining of the vessel getting damaged.
Right. That could help explain why recompression therapy sometimes seems less effective in certain animal models compared to its dramatic effectiveness often seen in humans.
Interesting. This is a really complex interplay of factors then. How does this wide range of potential effects actually manifest in real patients? What are the typical clinical features and how do doctors diagnose this?
The clinical presentations can be incredibly varied. I mean, really ranging from quite subtle neurological symptoms to profound, life-threatening cardiovascular collapse.
Depends on where the air goes and how much.
Exactly. It really hinges on several things. The patient's posture when the air enters, the specific route of entry, the total volume of air, the size of the bubbles, and the rate of entry. Was it a sudden gush or a slow leak?
Okay.
For example, as we touched on, if a patient is reclining when air gets into their veins, it's perhaps more likely to travel towards the coronary arteries.
Causing heart symptoms.
Potentially, yeah. Chest pain, arrhythmias, even heart attack symptoms. Conversely, if they're upright, the air is more likely to ascend via the carotids to the cerebral arteries.
Leading to brain symptoms.
Right, resulting in neurological symptoms. And the estimates suggest that neurological sequelae consequences affecting the nervous system occur in anywhere from roughly 19% up to maybe 50% of diagnosed cerebral air embolism cases.
That's a wide range, but still significant.
Definitely significant.
And for divers experiencing decompression issues, you mentioned the symptoms might not always be straightforward.
Exactly. It can be tricky. In about half of the cases diagnosed as dysbarism syndrome, that's the general term for pressure-related diving illnesses,
Right.
dysbaric air embolism is found to be a significant contributing factor, often alongside decompression sickness.
So what are the common signs in divers?
A sudden change in the diver's level of consciousness or mental state is very common. That could be anything from mild disorientation and confusion.
Feeling off.
Yeah, feeling off, maybe slurred speech, all the way to complete loss of consciousness or coma. Very sudden onset is typical. Focal neurological deficits can also occur, things like weakness on one side of the body, hemiplegia, or weakness in just one limb, monoplegia. Depends on which part of the brain is hit.
Makes sense.
Less frequently, patients might experience respiratory arrest, stopping breathing, or seizures. And in cases of massive air embolism, where a really large volume of air enters quickly, patients can go into shock, a state of circulatory collapse.
Wow.
There can also be associated symptoms that give clues, like a pneumothorax. The collapsed lung might point towards pulmonary barotrauma as the cause, or signs of myocardial ischemia, heart strain if the coronary arteries are involved.
Okay.
And there's even a somewhat rare but quite distinctive clinical sign called Liebermeister's sign.
Liebermeister sign, what's that?
It's the appearance of unusual, sharply defined pale or white patches on the surface of the tongue after an air embolism. Not always seen, but very specific if it is.
Pale patches on the tongue, that's definitely memorable. So it sounds like diagnosis heavily relies on recognizing these diverse signs and putting them in context with the patient's situation, right?
Yes, exactly. The diagnostic process really starts with a thorough consideration of the patient's history. What were they doing? Surgery, diving, trauma, and a detailed neurological examination.
Looking for those deficits.
Right. In situations like a sudden decompression event in a diver who then develops neurological symptoms, the diagnosis of air embolism is often, more strongly suspected from the outset.
Makes sense. What about during surgery? Can they detect it happening?
Sometimes, yes.
Hmm.
During surgical procedures where Doppler ultrasound is used for real-time monitoring of blood flow, particularly in neurosurgery or cardiac surgery,
Yeah.
the occurrence of air embolization, the characteristic sound or signal of bubbles passing, can sometimes be detected very early. That allows the surgical team to take immediate steps, like flooding the field with saline or changing the patient's position to try and stop more air getting in.
Proactive detection.
Yes. And transcranial Doppler studies, using ultrasound through the skull to listen to blood flow in the brain arteries, have shown that microscopic air emboli are actually quite common in patients undergoing cardiac surgery, even if they don't cause obvious symptoms.
The microemboli again.
Right. Two-dimensional echocardiography, and ultrasound of the heart itself, is also frequently used during open heart and bypass surgeries to directly visualize these microbubbles passing through the heart chambers.
They can actually see them.
Yes, you can often see a snowstorm effect on the echo screen. Additionally, continuous EEG monitoring, tracking brainwave activity, can be valuable for detecting early signs of cerebral dysfunction that might indicate an air embolism is affecting the brain, sometimes even before clinical signs appear.
So there are various technologies that can help spot these bubbles or their effects. What about more subtle signs, things that might not be picked up by a machine?
Subtle changes in a patient's mental function can be a crucial early indicator. Just not seeming quite right, maybe more confused than expected after a procedure, even if there aren't obvious physical signs like weakness.
Important to watch for.
Definitely. In some rare cases, air bubbles might even be directly visible during a fundoscopic eye exam. Looking at the back of the eye, you might see bubbles in the retinal arteries.
Wow.
If a patient is undergoing neurosurgery, the surgeon might directly observe air within the cerebral arteries in the operative field. Or, if an arterial blood sample is drawn for testing, the presence of visible air bubbles in the syringe can be a very strong indicator.
Okay.
But really, the most critical aspect of diagnosis is maintaining a high index of suspicion.
Assuming it could be air embolism in the right context.
Exactly. In any clinical scenario where it's a possibility post-surgery, post-procedure, diving accident, certain traumas should be assumed to be present unless there's strong evidence otherwise. Don't wait for definitive proof if the suspicion is high.
Because time is critical for treatment.
Absolutely. And sometimes the diagnosis is only really confirmed retrospectively by a clear and positive response to hyperbaric oxygen therapy.
The treatment itself helps confirm it.
In a way, yes. Oh, and in diving-related air embolism, checking serum creatine kinase levels can be helpful. It's an enzyme released from damaged muscle. Elevated levels can indicate muscle injury, often from the exertion of diving or seizures, and might correlate with the overall severity.
Got it. What about imaging, like CT scans and MRI? Can they definitively diagnose it?
They can be helpful, but they have limitations, especially regarding timing. CT and MRI can certainly identify brain lesions like small infarcts or areas of edema that may have resulted from the air embolism.
They see the damage.
Yes, and sometimes the air embolism itself can be visualized as pockets of air, low-density spots within the cerebral arteries on a CT scan, particularly if done very soon after the event. But a key challenge is that intracranial air can be absorbed by the body relatively quickly, sometimes within hours.
So the evidence disappears.
The air itself might, yes. While the infarcts, the areas of damage, might become more visible on diffusion-weighted MRI over the next day or so, the actual air bubbles that cause the problem might be long gone from the images by then.
Making it hard to confirm the cause was air.
Exactly. Plus, getting an emergency CT or MRI might not be practical or safe, especially if the embolism occurs during an ongoing surgery, or if the patient is unstable. And importantly, a negative CT scan, especially if done later, doesn't definitively rule out the diagnosis. The air could have been there and gone.
So imaging is useful, but not the be-all and end-all. It sounds like it's really a clinical diagnosis based on suspicion, history, exam, maybe some monitoring.
That's the core of it, yes.
Sure.
High index of suspicion in the right clinical setting is paramount.
Okay. Once a cerebral air embolism is suspected or confirmed, what's the immediate treatment approach? What needs to happen fast?
The fundamental treatment principles are actually quite similar to those used for decompression sickness in divers. It's about dealing with gas bubbles in the body. The immediate emergency measures are crucial. First, place the patient on 100% oxygen.
High flow oxygen.
Yes. administered through a tightly fitting mask, like a non-rebreather mask, to maximize the oxygen delivery to the brain and also help wash out the nitrogen from the bubble.
Huh.
Then, arrange for transport as rapidly as possible to a hyperbaric facility, a hyperbaric chamber.
The pressure chamber.
Exactly. If air transport is absolutely necessary, it's critical that the aircraft has a pressurized cabin and the flight is conducted at the lowest safe altitude, or ideally at sea level pressure if possible. You don't want decreasing ambient pressure making the bubbles expand further.
Makes sense. Any medications given immediately?
A single intravenous dose of a steroid like dexamethasone, maybe around 10 milligrams, might be given fairly early on. The idea is to try and mitigate potential cerebral edema, the brain swelling. Though steroid use is sometimes debated, it's often considered.
Okay, and the oxygen helps how exactly?
It serves two primary purposes. One, breathing 100% oxygen creates a steep concentration gradient that helps nitrogen diffuse out of the air bubble and into the bloodstream to be exhaled, effectively shrinking the bubble.
Pushes the nitrogen out.
Right. And two, it directly counteracts the hypoxia and ischemia in the brain tissue surrounding the blockage by significantly increasing the amount of oxygen dissolved in the blood plasma that is getting through.
Delivering more oxygen even with reduced flow.
Correct. Maximizing oxygen delivery to compromised tissue.
Getting the patient to a hyperbaric facility quickly sounds absolutely critical then.
It is indeed. Preparedness and anticipation are key. Ideally, medical procedures known to carry a high risk of air embolism shouldn't be performed in locations that are very far from a hyperbaric chamber.
Hospitals doing open heart surgery should have one nearby.
Ideally, yes, or at least have a very well-established rapid transfer protocol to a nearby facility. Time is absolutely of the essence. The data clearly shows the sooner hyperbaric treatment is initiated, the better the potential outcome.
And why is speed so vital, especially with large emboli?
With large air emboli causing significant symptoms, there's a very real risk of something called a gas log occurring in the right ventricle of the heart.
Gas log.
Yeah, where a large bubble essentially obstructs the outflow from the right ventricle, preventing blood from being pumped effectively to the lungs. This can lead to acute circulatory failure or cardiovascular collapse. It's an immediate life threat.
Wow. Okay, speed is paramount. You mentioned a generally accepted standard protocol for the hyperbaric oxygen therapy itself.
Yes, there's a widely accepted initial treatment protocol, often based on U.S. Navy treatment tables originally developed for divers. It typically involves immediate compression of the patient inside the chamber to 6 atmospheres absolute, or 6 ATA.
6 times normal atmospheric pressure.
Right. Using air as the breathing gas initially for a limited duration, usually no more than 30 minutes at that depth.
Why air first, not oxygen?
At that very high pressure, breathing 100% oxygen carries a significant risk of oxygen toxicity, causing seizures. So the initial deep compression is usually done breathing air.
Okay, 6 ATA on air for 30 minutes. Then what?
Then there's a gradual decompression, a staged descent, typically to a pressure of 2.8 ATA.
Still significantly pressurized.
Oh, yes. And at 2.8 ATA, the patient starts breathing 100% oxygen for extended periods, interspersed with short breaks breathing air to reduce oxygen toxicity risk. The total treatment time could be several hours.
Okay. And what's the rationale behind this specific pressure sequence? Why the initial deep dive to 6 ATA?
There are several key physiological principles at play. First, that immediate, significant increase in pressure physically shrinks the air bubbles trapped in the bloodstream. That's Boyle's law again. Gas volume is inversely proportional to pressure.
So 6 ATA makes the bubble much smaller.
Exactly. It reduces the volume to about 1/6, or roughly 17% of its original size. And importantly, it reduces the bubble's surface area to about 30%.
Why is surface area important?
Reducing the surface area is thought to lessen the inflammatory reaction happening at the interface between the air bubble and the blood vessel wall, and also makes it physically smaller, hopefully allowing it to pass through previously blocked vessels or reducing the blockage size.
Okay, shrink the bubble. What else?
Second, breathing 100% oxygen at that elevated pressure of 2.8 ATA dramatically increases the partial pressure of oxygen in the blood. The amount of oxygen dissolved directly in the plasma skyrockets.
Getting more oxygen to the tissues.
Way more. At 2.8 ATA on 100% O2, the arterial partial pressure of oxygen can reach around 1,800 millimeters of mercury, compared to maybe 100 normally. This results in about 6 milliliters of oxygen dissolved in every 100 milliliters of plasma, compared to maybe 0.3 normally. This hyperoxygenation directly counteracts the ischemia and hypoxia in the oxygen-starved brain tissue.
Flooding the system with oxygen.
Essentially, yes. Third, that high oxygen level also helps dissolve the bubble faster. According to Fick's law of diffusion, the huge difference in oxygen concentration between the blood and the primarily nitrogen bubble creates a very strong gradient pushing nitrogen out of the bubble and oxygen in. But the oxygen is quickly metabolized, leading to a net shrinkage.
So it shrinks it physically and chemically?
You could say that. And finally, hyperbaric oxygen, or HBO, therapy itself has beneficial effects beyond just the bubble. It's been shown to help reduce cerebral edema, the swelling, and lower intracranial hypertension, both major complications.
How does it reduce swelling?
One mechanism is HBO-induced vasoconstriction. Breathing high-pressure oxygen actually causes blood vessels and healthy brain tissue to constrict slightly. This can reduce overall blood flow into the injured swollen area, helping to decrease edema. Paradoxically, this vasoconstriction might also help prevent the redistribution of any remaining air emboli to previously unaffected areas of the brain.
So the healthy vessels tighten, shunting blood perhaps more effectively to where it's needed and reducing overall pressure.
That's part of the thinking, yes. And importantly, the reactivity of the cerebral arteries doesn't seem to be impaired by the embolism itself, so they can still respond to the oxygen stimulus.
So initial high pressure shrinks the bubble physically, then the high oxygen helps dissolve it faster while also treating the oxygen-starved tissue and reducing swelling. That makes perfect sense.
That's the rationale, yes.
But you also touched on some interesting experimental studies in animals that seemed to question the added benefit of that initial really deep 6 ATA phase.
That's a really important point and an area of some ongoing discussion among experts.
Yeah.
While early research in rabbits did suggest improved survival rates with HBO in general, some subsequent studies, particularly in dogs and later in cats, directly compared different hyperbaric treatment schedules. They looked at starting directly at 2.8 ATA on oxygen versus doing the initial 6 ATA air dive first.
And what did they find?
These later studies raise questions about whether that initial compression to 6 ATA with air provides a significant additional benefit compared to just starting treatment at 2.8 ATA on 100% oxygen.
Really? Why would that be?
Well, some of these studies suggested that the rate at which the air embolus is actually cleared or resolved might be more dependent on the concentration of inspired oxygen than on the absolute pressure, at least beyond a certain threshold, maybe around 2 ATA or so.
So the oxygen level is the main driver of dissolving the bubble.
That was the suggestion. They even indicated that oxygen administration significantly speeds up the resolution, potentially clearing bubbles in as little as 8 minutes in some of these animal models once high oxygen was started.
Faster than previously thought.
Perhaps. Furthermore, there were some concerning findings in the dog studies suggesting that the rapid decompression following the initial 6 ATA compression might, in some cases, actually lead to a redistribution of the air embolism to different parts of the brain or a temporary reduction in overall cerebral blood flow.
Which is obviously not what you want.
Exactly. So while the 6 ATA initial compression is still standard practice in many places based on historical success and the clear physics of bubble compression, these animal studies do add a layer of complexity and suggest that starting directly at 2.8 ATA with oxygen might be equally effective and potentially avoid some risks. It's still debated.
That's fascinating. So the established protocol, while effective, is still being refined and questioned based on ongoing research. What about those situations where a massive arterial air embolism is suspected, say, right after cardiac surgery? What's the thinking there?
In those rare but incredibly serious situations, where you strongly suspect a massive arterial air embolism has occurred during surgery, HBO therapy is definitely strongly recommended as soon as the procedure is finished and the patient is stable enough for transfer to the chamber.
Okay.
There are mathematical models that try to simulate how long it takes for gas bubbles to absorb in the bloodstream. These models predict that the time required is heavily influenced by the bubble's initial size and, crucially, the concentration of inspired oxygen.
Bigger bubbles take longer?
Much longer. For instance, even with a relatively high inspired oxygen concentration, say 40%, like you might get with a standard oxygen mask, the models predict it could take at least 40 hours for even very small emboli, like less than 1/10 of a milliliter, to completely absorb.
40 hours?
Now, and for larger emboli, the kind that might actually be visible on a CT scan, which are usually bigger, maybe 0.15 milliliters or more, the predicted absorption time is at least 15 hours, even with that oxygen.
Still a very long time for a blockage in the brain.
Absolutely. And importantly, any reduction in cerebral blood flow, which is often a consequence of the air embolism itself, would further slow down this absorption process because you need good blood flow to carry away the dissolved gas.
Right. Vicious cycle.
Kind of. Therefore, the recommendation is If a massive arterial air embolism is suspected, get a CT scan of the brain if possible and safe. If large air emboli are actually visible on that scan, then HBO therapy should be very strongly considered, even if it means transferring the patient several hours to get to a specialized facility. The potential benefit outweighs the delay.
Okay, so the general consensus is HBO is the go-to treatment for arterial gas embolism, especially with neurological symptoms. What about venous gas embolism, where the air is just on the vein side? Is the treatment different?
That's a good distinction. For venous gas embolism, where air has entered the veins but hasn't necessarily crossed over to the arterial side,
Yeah.
some experts recommend primarily supportive care, especially if the amount of air is thought to be small and the patient is stable.
Because the lungs can filter it.
Right, because as we discussed, the lungs are often quite effective at filtering out small amounts of venous air before it reaches the arterial circulation and causes problems in the brain or heart. So, monitoring oxygen, managing blood pressure might be enough.
But for arterial gas embolism,
For arterial gas embolism, where air has reached the arterial side and poses that direct threat to the brain or heart, HBO, combined with supportive care, is unequivocally the first-line treatment, no question.
and the decision to use HBO is based on symptoms, not where the air came from.
Exactly. The key criterion for initiating HBO therapy is the presence of clinical manifestations, especially neurological symptoms, suggesting brain involvement rather than solely the identified source or type, venous versus arterial, of the air embolism. If the brain is affected, HBO is indicated.
Okay. We've covered a lot of the theory and the protocols. What do the actual clinical outcomes look like when HBO is used for cerebral air embolism? Is it generally successful?
The outcomes are often really quite remarkable, and the data we have strongly supports the efficacy of HBO in this specific condition.
How much difference does it make?
Well, historically, looking back at cases treated with just conventional medical management, oxygen, supportive care, maybe steroids, but no HBO.
Yeah.
The overall mortality rate associated with cerebral air embolism was reported to be around 30%.
Nearly 1 in 3.
Yeah, quite high. However, controlled clinical studies and large case series have shown that when HBO therapy is administered, particularly if it started within the first 12 hours or so after the event,
Yeah.
the mortality rate can be significantly reduced, often down to less than 15%,
Halved, essentially.
or even better in some series. But there's a caveat.
Which is?
It does appear that the effectiveness of HBO diminishes significantly once irreversible neurological damage has already occurred.
Right.
If you wait too long, the tissue might be beyond saving.
Right. That pig study you mentioned earlier?
Exactly. That study, which showed no significant benefit of HBO on brain function when it was started 2 or 4 hours after inducing a very severe air embolism, highlights this crucial time-dependent nature.
The window of opportunity.
Precisely. Now, it's possible the injury in that specific animal model was just too severe to be reversed by a single HBO session, and maybe smaller injuries or repeated treatments would show benefit even with delays. More research is needed there, especially looking at real-world clinical outcomes in humans with varying injury severity.
But despite that, there are many documented cases of successful HBO treatment for air embolism from all sorts of causes.
Oh, absolutely. There are numerous case reports and clinical experiences published that demonstrate the successful use of HBO in treating air embolism that's occurred as a complication of open heart surgery, various endoscopic procedures, even things like transthoracic needle biopsies of the lung.
And they typically use that Navy Table 6 protocol or variations.
Yes, the U.S. Air Force modification of the U.S. Navy Table 6 protocol, that initial 6 ATA compression followed by the longer 2.8 ATA oxygen phase, is very commonly used and often highly effective.
Okay.
The chapter we've been drawing from actually includes a table summarizing numerous case reports. It's quite striking to see the range of situations where HBO has led to successful outcomes.
Like what kind of situation?
Things like air embolism during cesarean sections after cardiopulmonary bypass, following rapid decompression in flight, from hydrogen peroxide ingestion like we discussed, lung biopsies, even during procedures like endoscopic balloon dilation of the esophagus. The list goes on.
Wow.
What's also interesting when you look at these real-world cases is that the specific HBO protocols used can sometimes vary a bit, maybe depending on the patient's condition or the facility's capabilities. And the time from the event to starting HBO also varies quite a lot in these reported successes.
So while faster is better, success is still possible even with some delay sometimes.
It appears so, yes. It reinforces the idea that HBO should be considered even if some time has passed.
Okay, so the high pressure and oxygen work together. What about other treatments? You mentioned ancillary treatments used alongside HBO.
Yes, these are supportive therapies aimed at managing the secondary effects or complications of the air embolism, used in addition to the primary HBO treatment.
Like what?
Well, antiplatelet drugs, like aspirin, might be considered. The idea is to counteract that platelet activation and aggregation that gets triggered by the air bubbles.
Stop clots forming around the bubbles.
Or prevent further platelet-mediated damage, yeah. Heparin, a stronger anticoagulant, is generally riskier because of the potential for bleeding into any brain tissue that might have been infarcted.
Bleeding into the damaged area.
Right. Although, interestingly, some studies, particularly in the context of cardiopulmonary bypass, suggested that patients who were already on heparin before the embolism occurred seemed to have a slightly better prognosis. But starting it after the fact is usually avoided. Oral aspirin is generally seen as safer, though slower to act.
Okay. What else? Steroids?
Corticosteroids, like the dexamethasone we mentioned for potential early use, are sometimes continued or started later to help prevent or reduce cerebral edema. But their use alongside HBO needs careful consideration. There's a theoretical concern that steroids might slightly increase the risk of oxygen toxicity seizures during the high-pressure oxygen breathing phases of HBO. The evidence isn't conclusive, but it's a consideration. Also, delayed cerebral edema can sometimes still occur even after initial recovery, so monitoring is key.
Right. What about blood thinning in a different way? Hemodilution?
Hemodilution, yeah.
Yeah.
That involves increasing the fluid volume in the blood, often using substances like dextrin-40 to basically make the blood less viscous or thinner.
But why do that?
Well, a higher hematocrit concentration of red blood cells has been linked to larger infarct sizes in some stroke studies, and sometimes patients with air embolism can become a bit hemoconcentrated. The idea is improving microcirculatory flow.
But doesn't that reduce oxygen carrying capacity?
It does slightly lower the blood's hemoglobin-based oxygen carrying capacity, yes.
Oh.
But that's usually considered to be more than compensated for by the massive increase in dissolved oxygen achieved during the HBO therapy itself.
Ah, okay. Gotcha. Seizures.
If the patient experiences seizures, which can happen with cerebral air embolism, then standard anticonvulsant medications are necessary to control them.
Makes sense.
There's also some intriguing, mostly animal-based evidence suggesting that prophylactic use of lidocaine, normally used as a local anesthetic or antiarrhythmic, might not only help prevent seizures, but could potentially reduce the size of the brain infarct and also prevent cardiac arrhythmias that can sometimes occur.
Interesting. Lidocaine as a neuroprotectant.
Potentially, yes.
Yeah.
Not standard practice everywhere, but an area of research.
Okay. And finally, anything to support the brain's metabolism.
Yes, that's important too. Reduced blood flow leads to decreased energy reserves in neurons and an increase in lactate production, a sign of stress and anaerobic metabolism.
The brain running out of fuel.
Essentially. High blood glucose levels can actually worsen this situation and potentially increase the extent of infarction. So careful control of blood glucose is important. Avoid routine intravenous dextrose solutions unless needed for low blood sugar.
Keep sugar levels normal.
Right. And interestingly, some research suggests that HBO therapy itself might help normalize cerebral metabolism and could even help lower blood glucose levels, perhaps by improving overall tissue oxygenation and function.
So HBO might help on multiple fronts there.
It seems possible, yeah.
So it's a really comprehensive, multifaceted approach, not just getting rid of the bubble, but managing all the downstream effects. What about using HBO in some of those specific situations you mentioned, neurosurgery, cardiac procedures? Any special considerations?
Yes, there are definitely some nuances depending on the scenario. For instance, take secondary cerebral edema. You might have a patient who initially responds well to the 6-ATA compression. That's to improve, but then during the decompression phase, they start to deteriorate again, maybe becoming comatose due to swelling.
What do you do then?
In such cases, repeated HBO sessions, maybe just at the lower pressure of 2.8 ATA using 100% oxygen, can be very effective. These follow-up treatments target both any residual air embolism and the developing cerebral edema.
So you can adjust the protocol based on response.
Absolutely. In cardiovascular surgery, say an air embolism happens during cardiac catheterization in an infant. Prompt compression to 6-ATA, ideally within hours, often using just air, can lead to good recovery. Due to their small size and different physiology, 100% oxygen might not always be deemed necessary initially in very young infants at that depth.
Okay.
Another crucial point during any surgery, if nitrous oxide anesthesia is being used and an air embolism is suspected.
Stop the nitrous.
Immediately, yes.
Yeah.
Nitrous oxide diffuses very rapidly into air-filled spaces, much faster than nitrogen diffuses out. so it can cause existing air bubbles to expand significantly, making the problem much worse.
Good point. Turn it off fast.
Definitely. And HBO has shown good results for neurological deficits appearing after open-heart surgery that are suspected to be due to air embolism. Interestingly, even with delays sometimes exceeding 20 hours before starting HBO, benefit has been reported. Though the aim is always sooner, ideally within 48 hours for massive embolisms if possible.
So even delayed treatment can help post-cardiac surgery.
It seems so. There are even reports of more complex strategies, like using intraoperative retrograde cerebral perfusion, basically flushing the brain arteries backwards during surgery, combined with deep barbiturate anesthesia afterwards to reduce brain metabolism, followed by HBO, being successful in catastrophic massive air embolisms during infant heart defect repairs.
Wow, pulling out all the stops.
Exactly. And hypothermia, cooling the body, which is often used during cardiac surgery anyway for brain protection.
Yeah.
That might also have a synergistic benefit with HBO for air embolism. Basic physics, Charles's law, suggests cooling a gas reduces its volume, potentially shrinking bubbles slightly on top of hypothermia's own neuroprotective effects.
Interesting synergy. What about neurosurgery?
Air embolism occurring after posterior fossa surgery operations at the back of the head done with the patient sitting up.
The high-risk position.
Right. If it happens, it can often be promptly and effectively treated with standard recompression therapy, usually leading to full recovery if caught early.
And prevention is key there.
Absolutely. Prevention involves meticulous surgical technique, maybe using a modified semi-sitting position where the head isn't quite so high, avoiding hyperventilation, which can lower venous pressure, and using monitoring like precordial Doppler or transesophageal echo to detect air early. Plus, having strict protocols for patients known to have a PFO.
Right, the hardest defect.
Yes. For pulmonary barotrauma in divers, HBO generally has a good success rate, maybe around 65% or higher in reported series. Most seem to recover well with the 2.8 ATA oxygen phase, but the standard initial 6 ATA air compression is still typically used.
Okay. Any complications with the treatment itself?
Complications are rare, but possible. Pneumothorax, the collapsed lung, has actually been reported as a complication of recompression therapy for diving-related embolism, perhaps if underlying lung damage exists. And diversely, pulmonary barotrauma with air embolism has even been reported as a rare complication of HBO therapy itself, for instance, when treating a foot ulcer in someone with severe underlying lung disease. The pressure changes can affect vulnerable lungs.
Huh. So the treatment itself isn't entirely risk-free in susceptible individuals.
Nothing in medicine is entirely risk-free, but the benefits for confirmed cerebral air embolism vastly outweigh the risks in most cases. There have also been some very unusual presentations, like a case where someone became unresponsive with subcutaneous emphysema air under the skin during direct oxygen insufflation into their bronchus. It was presumed to be cerebral air embolism and was treated successfully with delayed HBO.
It really highlights how varied the causes and presentations can be. What about air embolism during some of those less common procedures or obstetrics? Any key takeaways?
Generally, for air embolism occurring during various invasive medical procedures, the prognosis tends to be quite good if it's recognized early and treated appropriately, including HBO when needed. Prompt action often leads to recovery without significant long-term damage.
That's reassuring. And in obstetrics.
In obstetrics, venous air embolism is a known, though thankfully rare, risk, especially during C-sections. Air can potentially enter the open uterine sinuses, particularly if the placenta separates early before the uterus contracts down.
Okay.
Successful HBO treatment has been reported in these cases, leading to good outcomes for the mother. There's also a striking case report of a patient developing cortical blindness, loss of vision due to damage in the brain's visual processing area after air embolism following an induced abortion that used intraamniotic hypertonic saline. She made a full recovery of vision after HBO therapy.
Wow, blindness reversed by HBO.
In that case, yes.
And you mentioned ERCP, the endoscopic procedure for bile and pancreatic ducts, is another rare cause.
Yes, hepatic portal venous air embolism is a rare but potentially devastating complication of ERCP.
How does it happen there?
During the procedure, high airflow is sometimes used, which can potentially increase pressure in the ducts, maybe cause tiny tears in duodenal veins, allowing air to enter the portal vein system, the veins draining the gut to the liver.
And if it gets past the liver?
If it gets through the liver and into the systemic circulation, reaching the lungs or brain, it can be fatal. A review back in 2010 found 14 reported cases of systemic air embolism after ERCP. 8 of those involved the brain, and tragically 6 were fatal.
6 out of 8 fatal. That's grim.
It is, and interestingly, only a couple of those cases had a PFO. In the others, It's assumed the air somehow got through the liver circulation or the lungs. Reports seem to be increasing, perhaps due to greater awareness or frequency of the procedure.
Any specific warning signs after ERCP?
Well, fatal cases have involved things like cardiac arrest, massive pulmonary and cerebral embolism found later, sometimes due to underlying issues like spontaneous fistulas. A key takeaway is, if patient fails to wake up properly or shows sudden neurological decline after an ERCP.
Suspect air embolism.
Exactly. Consider it high on the list. Get urgent CT scans of the head and chest. Maybe even consider attempting air aspiration from the right ventricle via a central line, or just proceed directly to initiating HBO therapy if the suspicion is strong enough.
That's sobering. A diagnostic test with such a potential risk. You also mentioned hydrogen peroxide poisoning again, causing gas embolism.
Yes, it's unusual but well documented. Hydrogen peroxide, especially stronger concentrations, decomposes rapidly in the body, producing water and a significant volume of oxygen gas.
Creating bubbles internally.
Precisely, leading to acute gas embolism. There are several case reports of patients developing stroke-like symptoms after ingesting hydrogen peroxide, sometimes accidentally, sometimes intentionally.
And HBO helps.
Yes, many of these reports describe rapid and complete recoveries following HBO therapy. One case involved hemiplegia, confusion, visual field loss after just a small ingestion. Initial CT was normal, but MRI showed ischemic changes. The patient made a full recovery after HBO.
What about cases not treated with HBO?
Interestingly, the report suggests that in the majority of cases of hydrogen peroxide embolism where HBO wasn't used, the patients did not experience a complete resolution of their symptoms.
Suggesting HBO is really crucial there.
It's led some experts to consider HBO as the definitive treatment for gas embolism, specifically caused by hydrogen peroxide poisoning.
A stark reminder about household chemicals. What about situations where someone seems to recover spontaneously? They have symptoms, then seem okay. Are they out of the woods?
Unfortunately, not necessarily. Apparent clinical recovery can sometimes be followed by a relapse of symptoms hours or even days later.
Why would that happen?
The reasons are likely complex, maybe multifactorial. It might involve that no reflow phenomenon kicking in later, or ongoing inflammation, or maybe tiny bubbles redistributing. A key factor seems to be a failure of adequate reperfusion blood flow not being fully restored to the affected tissue.
Can you predict who will relapse?
Currently, no. It's impossible to predict. And when relapse does occur, the prognosis is generally worse than if symptoms had persisted initially.
So what's the recommendation for someone who seems to recover spontaneously?
The strong recommendation is to promptly recompress these patients anyway while they breathe 100% oxygen, ideally with full HBO treatment.
Treat them as if they hadn't recovered.
Essentially, yes. The rationale is to counteract any ongoing, perhaps subclinical, inflammatory injury, limit any risk of reembolization from residual bubbles, protect other organs that might have been silently affected, help resolve any lingering edema, reduce the risk of late-onset infarction, and also, in diving cases, prevent delayed decompression sickness.
So spontaneous recovery isn't a reason to skip treatment. Got it. What about cases where there's a significant delay in getting HBO therapy? Maybe transport takes a long time or diagnosis is delayed. Is it still worth doing?
That's a really important practical question. While the mantra is always treat as early as possible, the answer is yes, there's still potential benefit even with significant delays.
How much delay are we talking?
There are documented cases in the literature of patients showing significant recovery even when HBO was started quite late. For example, patients with severe neurological deficits have improved even when HBO began up to 24 hours after the event.
A full day later.
Yes. And in cases related to things like bypass accidents, ventilator barotrauma, or central line issues, meaningful neurological recovery has been seen in patients starting HBO anywhere from 15 hours to as long as 60 hours, 2.5 days after the initial incident.
60 hours? That's remarkable.
It is. It suggests that even if the initial ischemic damage has occurred, HBO might still help salvage surrounding tissue, reduce edema, promote healing, and facilitate recovery even days later.
That's certainly encouraging. It really underscores that HBO should be considered even if time has passed.
Absolutely. The overwhelming consensus, based on decades of experience and evidence, is that HBO therapy is unequivocally indicated for cerebral air embolism, especially when there are neurological deficits. Conventional treatments alone are often just inadequate for this complex problem.
And the 6 ATA start is still preferred, but 2.8 ATA oxygen is acceptable.
Right. While initial 6 ATA air compression is still favored in many protocols for the reasons we discussed, starting with 100% oxygen at 2.8 ATA is considered an acceptable and effective alternative, particularly if getting to 6 ATA isn't immediately feasible or poses other risks.
And early diagnosis is key.
Absolutely crucial. And there's a real need for better, faster, more accessible detection methods. But given the importance of time, if cerebral air embolism is strongly suspected based on the clinical picture.
Treat first, ask questions later.
In many cases, yes.
Yep.
Proceed with hyperbaric compression. The patient's response, or lack thereof, can even provide further diagnostic confirmation. Early treatment is always better, but XBO should still be considered at almost any stage if neurological deficits are present.
And ideally, the facility should be available.
Logically, yes. Hyperbaric chambers should ideally be readily accessible at or near medical centers performing high-risk procedures like open-heart surgery or complex neurosurgery. Preparedness is key.
Okay, so to kind of recap our deep dive then, we've learned that cerebral air embolism can pop up from a surprisingly wide range of causes, with medical procedures being perhaps worryingly the most common culprits. The ways these bubbles cause harm are complex. It's not just the physical blockage, but this whole cascade of inflammation and biochemical reactions.
Right, the body's response is part of the problem.
Diagnosing it is tricky. It needs high suspicion, careful assessment, sometimes specialized monitoring, but imaging isn't always definitive and shouldn't delay treatment.
Clinical judgment is paramount.
And the cornerstone of effective treatment is definitely hyperbaric oxygen therapy, HBO. It's shown remarkable success in improving outcomes, often leading to significant, sometimes unexpected, neurological recovery.
It really is the mainstay of therapy. What's particularly striking, I think, is just how common those microscopic air emboli might be during routine cardiac surgery, something most people, even many clinicians perhaps, aren't fully aware of the potential implications of.
Yeah, that's unsettling.
And then you have these much rarer but really dramatic causes, like the ingestion of hydrogen peroxide leading to a systemic gas embolism. I mean, who would think? It's a truly unexpected way for air or gas to cause such significant harm.
It really makes you think, doesn't it? Particularly about the accessibility of these hyperbaric chambers. You know, given the potential for iatrogenic air embolism caused by medical care itself, are these specialized treatment centers as readily available as they ideally should be, especially in hospitals doing the high-risk procedures?
That's a critical healthcare infrastructure question, definitely. Access varies significantly.
And maybe thinking beyond the immediate treatment, what about the long-term effects for people who survive a cerebral air embolism? What does rehabilitation look like? And are there maybe subtle long-term neurological or cognitive issues that we don't yet fully understand or maybe even recognize after these events?
That's another crucial area. Long-term follow-up and understanding the full spectrum of recovery, or lack thereof, is certainly an important avenue for future research and improved patient care. There's still more to learn.